I want to start first by telling you what it is I plan to say, and then I'll say it, and then I'll come back at the end and claim this is what I said. So what I want to do is to reflect on the title, which is, what if everything causes dementia? Which I think is true in a certain way. If it is true, that means that at some point, aging and disease, at least Alzheimer's, are indistinguishable. And that has, if this is true, which my claim is that it is, that has profound implications for the way we organize clinical care, and indeed for the way we think about aging. And I am coming to the view that that is true, and I think it's sufficiently important that we should publicly begin to engage in the discussion about that. Because the stakes are very high, particularly in Canada where we value publicly funded medical care. So I'll come back to that point. I'm going to summarize for you the evidence for why I think that's true. I'm going to, as academics do, I'm going to tell you evidence that counters it, right? On the one hand this, on the other hand that, but hopefully it'll be clear why I make this claim. I'm then going to depart a little bit from the dementia remit per se, and just talk about the way in which we organize clinical care. If this is true, it will have implications for how we provide clinical care, and we best think about them right now before the wave of aging hits. It will certainly have implications for the way we train our doctors and nurses and other healthcare providers. And because the lead times are so long, we best think about it now and not wait till we feel that we're swamped. It's likely going to change what we expect as individuals from clinical care, both for ourselves and for our family members. I'm hoping it will make some difference to what we imagine our social norms to be, and I'm going to use examples from recent correspondence and editorials in the Globe and Mail to show how we've got two very different views about aging now and how we need to find some way to think about them. And of course, being Canadian, I will propose that we take the middle ground. I think it has something, if we imagine that there's a point at which aging and Alzheimer's are the same, and if we really believe that to be true, it would also have some impact for what we believe our expectations for age to be, and what we think would constitute successful aging. And then I'll come back to the dementia stuff per se, and I'll talk a little bit about the scientific agenda with respect to how our understanding and approach to the science around this must change if we move back from the relentless progression model of Alzheimer's and think about different ways. Then I think that will be interesting and exciting and informative for us. And I'm going to propose to you that Halifax is a reasonable place to do this for a very pragmatic reason. If we're going to engage in research in a very serious way, which people do here, but if we're going to take it to the next level, for which there's every opportunity, then we need to think carefully about what our advantages are here. And as near as I can tell, we don't really have a technological advantage. We have certain technologies that we bring to bear, but the people with the true technological advances are the folks who make those technological machines, right? In high-tech medicine, by the time it arrives, it's obsolete. By the time you're unpacking it from the truck, there's one in a warehouse somewhere that is even fancier than the one that you've got. So having a strategy in which we imagine we should tie ourselves to technology, as important as technology is, I don't think is as good as if we tied ourselves to things that we can do well. I'm going to talk a little bit about what I think that is. The final thing I will want to say in terms of the implications for what we do is again, the sort of softer, quasi-philosophical idea about how we think about the entire enterprise. So that's what I aim to say. I probably have taken half the time I'm going to use to say it now, but there it is. That's the general outline. But before I get into the substance of this, there are two things I'm very keen to say. One is that I approach this with tremendous optimism. If you go out of here tonight feeling gloomy about it, then I haven't communicated what I really feel is a very optimistic understanding of how things might play out for us if we do this well, if we do it thoughtfully. The other thing that I want to make clear and to underscore is the amazing sense of privilege that I feel to do the work that I do. It's a very privileged spot I'm in to be able to combine clinical care with research and to do it in such a warm and welcoming environment as I find myself in here. So I hope that you will be persuaded of that by the time I'm done. But let me say that explicitly at the outset. So let's go back. What's the starting point? What if everything causes dementia? So what do I mean by that? This is a conclusion that I'm coming to, and I'm mostly there, over the last 3 years in particular, and in particular as a consequence of a couple of studies that we've been undertaking in the last 2 or 3 years with my friends and colleagues Xiaowei Song and Arnold Meninsky, who are in the audience with us tonight. And we published 2 papers this year, one in May in the Canadian Medical Association Journal, and the other one in July in the journal Neurology. And these two underpin, these are the evidence base for why I would imagine this is going to turn out to be true. So the paper that we published in the CMAJ was based on work done by Statistics Canada, that sometimes curiously maligned organization. It was evidence. Hopefully we'll still be allowed to talk about evidence. Nationally collected evidence done at taxpayer expense. So the National Population Health Survey was started in 1994. They followed through about 17,000 people. They see them every 2 years, and they make successive ways available to researchers for the analysis and publication thereon. And it's a tremendous resource to taxpayers, and we have access to it here. So what we found over the period of looking into these data, how they were followed up each 2 years, what we found was that as people got older, they had more things wrong with them. Okay, I just want to make sure you weren't too shocked by it. Yeah, so as people got older, they had more things wrong with them, and more than that, the more things they had wrong with them, the more likely they were to die. Yeah, okay, I'm done. Thank you. So it's good to start with work that's at least not counterintuitive. So as people got older, they had more things wrong with them, and the more things they had wrong with them, the more likely they were to die. But the trick is that not everyone got more things wrong with them at the same rate. But within limits, most everyone died at the rate at which they had things wrong with them. So this is a really important challenge for how we think about healthcare. Because in healthcare right now, we're making 2 mistakes, 2 problems we're inflicting on ourselves. One is because many old people have lots wrong with them, and because lots of people with lots wrong with them have bad outcomes, we are confusing age with having many things wrong. And as a consequence of that, we are committing 2 errors. One is, for some people who are very old but have little wrong with them, we're not doing enough for them. And for other people who are older and have many things wrong with them, we're doing for them things that are not helpful. By far, the second problem is our bigger problem. We're doing too many things to too many people who have a lot of things wrong from which they cannot possibly benefit. In fact, not only can they not possibly benefit from these things, but they are actively harmed. So as a consequence, we are in the perverse state of spending a lot of money to achieve bad ends in people who have many things wrong with them. And unfortunately, we don't have a good handle on that. So even though at the outset it seems very straightforward, the older you are, the more likely you are to die, but the older you are, it's not because you're older, it's because you have more things wrong with you. It's the more things you have wrong with you that makes you likely to die. Those are very straightforward. But the idea that we need to have some way to figure out what's wrong with people of a certain age as they come to the hospital so that we can rationally plan care that will be helpful to them and not harmful, that's proving to be a really tough nut. That's a really difficult problem for us to get our arms around. The alternative to thinking about it in these terms is we use very regrettable and unfortunate terms, and we use analyses such as the problem in the acute care hospitals is we have all these people with subacute care needs who are blocking our beds. And if we think of the problem in that way, we have absolutely no hope to rationally or usefully solve that problem. So the first thing that we looked at was that the more things people had wrong with them, the more likely they were to die. And so then and two things came out of the analysis, and this is something we've known for a while, done in the way that it was, but two things came out of this. One was we showed that this trend started at about the age of 15. So from age 15 on, we're able to detect signals such that people with more things wrong are doing worse. And the other thing that was clear was that the extent to which people accumulated the things they had wrong with them was extremely characteristic for the individuals. So that at a group basis, the numbers increased in a very clear way, which didn't deviate very much from one year to the next. So that means that the idea of counting things that people have wrong with them and understanding that in relation to their health needs and their prognosis is not just a phenomenon of someone's chronological age, but it's a fact of how they've aged from a biological perspective, if you will. So there are many, many other implications that flow from this piece of work, but I want to concentrate now on just one of them, which is what happens at the very extreme end of life. So past the age, pick an age, 80, 85, 90. Statistically, these are all achieved on a fairly uncommon basis. So what happens at these ages now becomes a focus for us to understand how to apply this way of thinking about what people have wrong with them and what happens to them. So that was the first starting point, was that simply counting what people have wrong with them is very informative, and it works out in a very stereotyped way. Now what we did in a related body of work, using data from the Canadian Study of Health and Aging, was we went back and reanalyzed information on 10,000 people who've been looked at for over 10 years. So I was a proud member of the Canadian Study of Health and Aging for many years, and I was very glad to make contributions to the understanding of what the risks for Alzheimer's disease were. And so I was glad to contribute to a body of work that both in that study and other studies done around the world said more or less these things. It said, things that are bad for your heart tend to be bad for your brain too. So high blood pressure is bad for your heart, gives heart attack. Bad for your brain, gives stroke, but also bad for your brain because it gives rise to Alzheimer's itself. And that was a change in the way that we had thought. So for people who haven't paid close and intimate attention to this area, let me put it for you like this. It used to be said, when I was a boy growing up, my grandfather had dementia. That is to say, he had many problems with his thinking and his memory and his cognition. I'm sure if we tested it with his language and his drawing and his calculation. And that these things were severe enough to interfere with him living life the way that he had wanted to. He became increasingly dependent on my grandmother. So he met the dementia criteria. He had many cognitive thinking, memory type problems, and they interfered with the way he lived his life. There are things he couldn't do anymore. That's what dementia means. Except we didn't call it that in those days. What we called in those days was senility. And we thought that the cause of it back in those days was hardening of the arteries. And then Martin Roth and other people came along, and particularly in some papers they published in the 60s and the early 70s, which to some of you in the room will seem like ancient history, and other people say, well, yeah, that wasn't so long ago, really, was it? So work that was done then, they said, hang on, it's not senility, it's dementia. The difference is senility just means aging. Dementia means this illness in the brain that impairs function. And when Martin Roth and others looked at brains carefully, they said that there were things inside the brain, plaques and tangles, which went by the label, could go by the label of Alzheimer's disease. They said, and they were right. And they said Alzheimer's disease is what the cause of senility is. It's not aging, it's an illness. And it's not, therefore it's not senility, it's dementia. And it's not hardening of the arteries, they said. It's this intrinsic neurodegenerative process. The brains themselves are deteriorating, and the pattern fits with what Alzheimer had described at the turn of the 20th century. So the idea that it was senility due to hardening of the arteries was replaced, that it was dementia due chiefly to Alzheimer's. That was in the 70s. By the 90s, people had come back to the view, but with a much more sophisticated understanding. And they said, look, we can actually find people who clearly, no one used the term senility then, and no one used the term hardening of the arteries either. We had advanced, we called it cerebral atherosclerosis, which I'm sure you'll agree is a much better thing to call it. And so what we said at that point was that Alzheimer's disease was related to high blood pressure and hypercholesterolemia and other, increased cholesterol and other things that gave rise to stroke. So a big part of the effort that had been done in the 80s and up to the mid-90s to put the wall up between, on the one hand, Alzheimer's disease and on the other hand, vascular dementia, in the mid-90s we started to take that wall down. And this constitutes scientific progress. And so the work from the Canadian Study of Health and Aging contributed to that, and I was happily in the line of the people who did that work. But as we worked more and more on that, one thing became kind of interesting, which was that a lot of things seemed to give rise to dementia. So, for example, it wasn't just things that were bad for your brain, but being knocked out for at least 24 hours at some point in the past seemed to increase the risk. Having a father or a mother or a sister or a brother with Alzheimer's increased the risk. Being exposed, particularly as a farmer, to organic pesticides that were neurotoxins, that was a risk too. And so at the back of my mind at that time, I said, these risks don't have a whole lot in common. There's not a lot that hypercholesterolemia and neurotoxins at head injury and family history each in and of themselves share. And it occurred to me that perhaps what Alzheimer's was not an illness that came about as a consequence of a single cause. It was an illness that came about as a consequence of the brain trying to repair itself and failing to do so, of the brain undergoing an aberrant, a faulty repair process. And we did a little bit of work on those lines during that time. But by the time the thinking had come round to the paper we published a couple of months ago, I was really keen to push that as far as it would go. And I said, what if we did this? What if we came up with a series of risk factors or a series of things wrong with you that have nothing to do with the known risk for dementia. So let's take some things like a problem with the bowel, or ever having had a fracture, or wearing dentures, or stuff like that, that are not known to be associated with dementia. And what if we went back to the idea that we had in the other paper and said, let's count up things that people have wrong with them and see if the more things they have wrong with them, the more likely they are to get dementia. But the trick here was that everything we counted, as far as we knew, had nothing to do with dementia, and not plausibly so. And in fact, when we tested it in the study, the individual items that we looked at 19 of them that we were able to find. They happened to be in the questionnaire that we had used, and they didn't have anything to do with dementia. So we counted them all up, and actually 14 of the 19 on their own had, not even by a fluke chance, not even by a remote chance individually, had anything to do with that risk. But when we totaled them all up, when we put them into a single variable, what we found was that the more things you had wrong with you, even when these things had nothing to do with having Alzheimer's, the more things you had wrong with you, the more likely you were to get dementia, the more likely you were to get Alzheimer's. And this held in this magnificently well-characterized Canadian study of health and aging. And it held even when we compared these risk factors taken as a group turned into a single variable with any of the known proven risk factors. In fact, it was such a strong predictor that it diminished the effect of the other risk factors. It made them go away. So that turned out to have been news, and that was published in July, and I've never in my life had such a flurry of people trying to get hold of me. So I talked to CNN and Time Magazine and the New York Times and all these places, heady times for a week or two. And it turns out that no one gave me anything close to the amount of time I just had to explain to you what was going on. And what they wanted was a 30-second soundbite. And it turns out that there is more or less in everything, particularly in the US media, kind of a left-wing way to view things and a right-wing way. And the right-wing way is make it as simple as possible and talk about dentures. And the left-wing way is kind of make it fuzzy and say, you know, someone should do something about all these things. And you know, actually what the left-wing press said more or less was, you should be as healthy as possible, which is sound advice. And certainly if I had to make the preference between you should be as healthy as possible and there's something about those dentures, I would go for the be as healthy as possible take on it. But the idea was, from my standpoint, more profound than that. It was more satisfying to be involved in it. It took more thinking and working through. But the idea was that things that have nothing in common with each other, as far as we can tell, nor are associated with Alzheimer's, are powerful predictors when combined to cause, or to be associated with, cause is a big word for a doctor, to be associated with Alzheimer's. And then we started to push that thinking. And that was what led me to the conclusion, that's why I stand here before you and say, there's a way in which everything causes Alzheimer's. But there's now a lot of nuance. It's not as simple as that. If you're from the right-wing press, you can go home now. So the idea is that this is only true at a certain age. So it turns out that of the 19 things that we toted up, you could have pretty much any 5 of them, and the risk for Alzheimer's was not increased. But when you got over that threshold, when you got into 6 things wrong, it started to uptick, and then it went up sharply. 6, 7, 8, 9, 10. It all goes up with that. So what's that telling us? Well, another way to think about the way that people accumulate things wrong with them is it's the way that time expresses itself in them, right? It's a big idea. The way that time expresses itself in them. So one way to measure time is you get your clock out and you look at the amount of time that has gone by, and that's objective and quantifiable, and you can standardize it from one group to the next and so on. It has a lot of things that are extremely attractive about that. But are there any dentists here, by the way? Just out of, no one who is a dentist admits to being one? Because I mean, one of the things that one of the right-wing US networks did was to find a dentist who didn't think that it was right to say that dentures didn't cause dementia, and he was pretty sure they had, and so on. And so do you know what I said? Well, he may well be right. And boy, they hated that. So I'm not picking on the dentist at all, but still, you'll know what I mean when we're talking about time, and I say there is clock time, objective and all sorts of stuff. There's also experiential time. So time spent in a dentist's chair, for example, moves typically more slowly than time spent in other circumstances, watching TV and such. So even though there is objective time, it's not all that it's and it's extremely helpful and so on. I'm not against it. It's not all that it's cracked up to be. It is not necessarily as helpful as we think that it might be. And we are every day familiar with variable ways that time passes. So in a sense, you can think about the number of things wrong with you, the way that you've experienced time from a biological standpoint, right? And that, again, this is not hard. Everyone knows, some people are hard-living people, right? They pack a lot into a short period, and their body bears the brunt of it. So it's a way to think about it in them biological age. And so it turns out that if we look at the analysis through that lens, there's the point at which the presence of dementia is indistinguishable in terms of the shape of the curves and so on. It's indistinguishable from the passage of time. It's indistinguishable from aging. Anyone who lived long enough or lived hard enough to accumulate a certain number of things wrong with them at a certain point well before they might die, right? Because remember, the more things are wrong with them, the more likely they are to die. But before they get to that point, they will, from a number standpoint, look exactly like they have dementia. So this is an intriguing idea. So I then wanted to reflect on other scientific work that was done to see whether this makes sense. And it turns out there's a mountain of stuff to show that it makes sense. I'm just going to cite two papers or two studies. One was done in the UK, funded by the Medical Research Council of the United Kingdom. And it was called the Cognitive Function Aging Study, or the CFAS study. And what happened there was that free-ranging older adults, very old adults over the age of 85, agreed to be studied. And they said, from now till the day I die, which for some 85-year-olds is not that long and not that far away, nor do they expect it to be. So, but from now to the day, once a year, every year I'll go in and you can test my brain function in various sexy ways. And we'll see what happens when I die. When I die, you can take my brain. So this is scientific research volunteering to an extremely high level of commitment. But that's what they agreed to. And when the pathologists looked at their brains under the microscope and then looked backwards to the extent to which people experience memory loss and impairment and so on, and met the diagnostic criteria for first dementia and then Alzheimer's, they found that there was no cut point of the number of plaques or tangles or other fancy things that people had wrong with them, none of the hallmarks of the disease under the microscope, which up to then had been held to be the gold standard for a dementia diagnosis, none of those, there was no cut point that correlated with the actual fact of dementia in carefully studied people. So if you're a glass half empty person, you could say they all had Alzheimer's because they met, in other words, they met the neuropathological criteria, they met the brain autopsy criteria, they met the microscopic look under the microscope at the brain criteria for Alzheimer's, but they didn't actually have it. If you're the sort of person who can't tolerate that seeming paradox, you would say, well, they actually had Alzheimer's, and if only those tests were better, if only those cognitive tests were better, they would have picked up the Alzheimer's that they have. But that is simply not plausible looking at the amount of testing that was done and the time intervals that was there. So in other words, there are many people walking around who, if you killed them and took their brains, which hitherto we had imagined was always the best way to make an Alzheimer's diagnosis, though we didn't go that far, we just call it the definitive diagnosis. We held it up sort of a metaphysical ideal that we could never achieve, right? If only we could kill and take away, we'd know for sure, we'd say. But even if you could, it turns out you'd be wrong. There are people walking around with all the setup, all the hallmark of Alzheimer's who don't have it. And that is a huge scientific opportunity. And it fits with the idea that the accumulation of things wrong at a certain point will make it look as though you have Alzheimer's when you count the things that people have wrong with them. it immediately gives rise to another idea, which satisfyingly comes out of the mathematical work that we have done, which is that the brain must fight back. And I'm going to park that idea, come back to it in a second, park that idea right now to say it isn't just this one curious MRC CFAS, the Medical Research Council Cognitive Function and Aging study, which showed that. Other studies have shown this too. In fact, it's generally the case that the autopsy studies that have been based in communities that have studied people who haven't come to clinic has found this. Whereas by contrast, extremely detailed studies of people who were patients have found that the correlation is much higher. But that's because they didn't study people who didn't have anything wrong with them from a cognitive standpoint. When you look at both sides of the equation, the formerly clear picture now becomes very murky. If you're really inclined to believe that the neuropathology must be true, that the plaques and tangles and what's looked at under the microscope must be truly what's going on, you'll find great comfort in a paper that came out a couple of months ago in the journal Brain, which is an extremely high-end, prestigious journal done by very, very intelligent and sensitive and careful and thoughtful people. So it's a dilemma for me to come up with a view which is so much against this work done by people that I know and respect. But even so, that's where I find myself right now. So we've synthesized a lot of this information in a paper with a colleague of mine, Philip Sheltons, in Amsterdam, and published it last month in the journal Alzheimer's and Dementia. So if you're really kind of keen to look into that, those are the appropriate references. So let's come back. So what I've said so far is that as people get older, they have more things wrong with them, but it's the more things they have wrong with them which is important. It's the more things that they have wrong with them which makes them more likely to die. That's, as a general rule, apart from running into a bus or some such thing. That's why people die as they get older. It's not their age, it's the things they have wrong with them, as a general principle. And then I said we can extend that. The more things you have wrong with you, the more likely you are to get dementia. And now I've put an important nuance, a couple of them in there. The things you have wrong with you doesn't matter whether they're individually associated with dementia or not. It's this more things wrong with you idea, which is very important. And now I've said that a really important challenge for us is that these more things wrong with you can make it look like under the brain under the microscope that you have dementia, when it turns out that you don't. And so the only way that that works is that this must be half of the ledger, as though we're only looking at the costs and we're not looking at the benefits, as though we're only, God knows, no doctor knows accounting, this I understand for sure. But pardon me if I'm looking down at my son who's doing accounting, so I make sure I don't say anything too wrong. But the idea is that we're only looking at one half of things. We're only looking at the cost. We're not looking at the good part of it, whatever accountants call the good part of things. The assets. The assets? Okay, the assets. So we're looking at the cost, not the assets. When we look at the whole picture, we find that many people walking around whose brains look as though they should have Alzheimer's, it turns out that they don't. Now, that means the brain fights back, and I won't go into the mathematics of it except to say that we have a very sound basis to expect, believe to be true, that the brain must fight back, that in fact the body must fight back. But then there becomes an age at which the fight back response, even when it's present, makes only a marginal difference to us. It only gives us a marginal account, a marginal way in which we improve. We will never get back to the good state. So from the dementia analysis standpoint, it would be as though there's a point in which if you had moderate dementia, you can improve to having maybe mild, but you could never improve to having none, or even the pre-dementia state. And because the expression of this is through time, and time is measured through chronological age, in any pragmatic sense, there's a point at which aging and disease, at least Alzheimer's, are inseparable. And even the clinical expression of them, at a certain point, the die is cast. There's a tipping point. There's a way that we can't go back. Now, right now, it's at the very end of life, by which I mean over the age of, and here we'll have to pick the numbers carefully, over the age of somewhere between 88 and 92. And we all know people who are older than that, sharp as a tack and so on. And that's not what I'm talking about. I'm talking about things from a statistical standpoint. I'd even say if you had to show me a 102-year-old who was sharp as a tack, I would even say, after I said you were lying, I would even, because they may be fine, but they wouldn't, their neuroprocessing speed would not possibly be as good as it was when they were younger. So I would say that the real trick now is to understand what their biological age is. But even short of that, even just accepting that there may even be a few outliers, for most people, for the most part, aging and disease will be inseparable. And really what changes is the type of illness that they get. The Newcastle study of aging, there's a new Newcastle study of people over the age of 85. They published a very important paper in the BMJ in 2009, and it showed that no one over the age of 85 had nothing wrong with them. Even the fittest people that they had something. And this is a very important conclusion, that probably to my parents, you know, the people, the best generation, right? The people who fought the war, went through the Depression, did all the stuff, you know, started Medicare, gave us this great legacy, which we now have to be careful we don't break. You know, wow, sorry we couldn't help it. We all lived to be older than you would have thought, and now we can't afford it anymore, is what we're going to say if we're not careful, to our shame. Those people I don't think would have had any problem with saying, well, there's a point at which, you know, everyone's got something wrong with them. But I'm concerned that the boomers, of whom I count myself as one, are going to be less inclined that way. And they're going to say, but I can't have it anymore. I eat yogurt and I do yoga and I, you know, subscribe to the right journals and, you know, look at these Birkenstocks. These are fabulous. How can anything be wrong here, right? And for individuals, that may be fine. But there's no way to conduct public policy. And so we see right now in the Globe and Mail this very interesting exchange that's going on. Economists who are extremely clever, and again, as I say, you know, I know the mantra of the financial planner, a physician and his money are soon parted, is I think what they say. So, you know, I talk about money with a certain hesitancy. But even so, the clever economists are routinely able to do an analysis of healthcare expenditure in Canada and make the effect of aging virtually go away. And, you know, good for them, but that's a party trick. No one who actually works in healthcare could believe that's true for a single instant. Now, what they say is, we've made the effect of aging go away because now what we're counting as what the real cost drivers are technology, particularly the cost of drugs. So I don't want to ignore that because in Alzheimer's, this is going to be a very real area for us. This is going to be a very real concern. This is going to be a very real debate for us. Is the high cost of the drugs that are going to be in the next generation of drugs for Alzheimer's, if they come about, please God, they will. But that's a party trick. And the Globe and Mail, in an editorial a couple of weeks ago, the Globe and Mail, who should know better, endorsed this party trick. They said, look, there's all this crying about an aging population, and we can make, look, there's a group of economists that published in this journal, they made the effect of aging go away, there's nothing to worry about. And policymakers for a long time, that's been the line that chiefly they have been fed, in part because the other line, the catastrophe line, the time bomb line, the tsunami line, who can plan for that? So isn't it better if someone comes and says, no, don't worry. As a consequence, we have healthcare institutions all across Canada which largely are unprepared for the aging of the population. Even at this late stage, right? The baby boomers turn 65 this year. 65 is okay. At 75, where if there's going to be an age-associated catastrophe, that's when it will occur, 10 years away. It takes at least 10 years to take someone who you get in to medical school and get them out the other end as a geriatrician. This is kind of, we're coming up to our last chance now to get this right. The time to think about this and act on it is now. It's critically important that we understand how aging works. And the thing about aging is that when people have one thing wrong with them, we have an extremely good system for healthcare. I saw a friend today who was on his bike and he fell down at a face plant and he had a big smash to his face. And with a very short time, an ambulance was there. With a very short time, he was in the emergency department. With a very short time, he was seen by all the appropriate people. He had a CAT scan done and so on. There's no waiting, there's no wait list, there's no nothing. He was looked after in an extremely appropriate way in a very quick period of time. Our healthcare system, our hospital here is extremely good at things like that. If you have people with only one thing wrong, this is the place to go. There's no doubt about it. We need not take a back seat to anyone. I mean, sometimes you got a squeeze system, push it and all this sort of stuff, but it can be done. Where we here in Halifax, and when we across the country are falling down, is when we have people who have many things wrong. And the trick is we haven't associated how the many things wrong work. The many things wrong work as a consequence of the fact of an aging population. And we have to plan for that now. So as we reflect on what it means if everything causes dementia, it's likely going to be true that everything causes heart disease as well. I'm now speaking outside my data, but I'll bet this is true. And I'm trying to get hold of a data set now that characterized heart disease as well as the Canadian Study of Health and Aging characterized dementia, but I'll bet it's true that that everything will cause heart disease and everything will cause cancer and so on, because multiply determined illnesses that occur in very late life are likely to be caused by the body losing the ability to fight back, which is in essence what aging is. I've considered some of the consequences of it. I want to underscore now a couple of consequences with regards to healthcare. It's very, very important that we understand that the skill set required to manage people who have many things wrong is not a negative skill set, it's a positive skill set. Geriatrics is not what we do when we're too stupid to do anything else or too lazy. Geriatrics is an active area of inquiry in which there are complex, multiple interacting medical and social problems, which we embrace, people in geriatrics embrace. It's not the sort of work that anyone can do. When we find people who can do this sort of work, we embrace, well, they might be girls and they can't really embrace girls if you're a guy and so on, but you know what I mean, right? Not if you're a professor or guy in any event. But we kind of bring them in and celebrate them and say, you can do this great thing. The complexity of need is a really important issue for us. We need to honor what it takes to manage complexity, and then we have to show the positive skill set that it takes to do a good job with people who have many things wrong. Far from being subacute patients who are blocking our beds, they're probably the very best test we have of how good our healthcare system is. Because if you can manage people with many things wrong, with social problems on top of that, the one thing wrong at once, folks, will be a piece of cake. So we really need to look at these people as our best test, our most important challenge, the way that we can shine, and not as a terrible group of people have been inflicted on us and hopefully they'll just go away. This will also turn out to be an extremely important problem when it comes to Alzheimer's. I will tell you that I have looked after people in their 30s with Alzheimer's. I know all too well what Alzheimer's as a disease looks like. And for people like that, the $2,000 a month that it will take to give them the specific anti-amyloid antibody treatment to prevent disease expression in them will be money extremely well spent. But I will find it very hard to stand up and justify $2,000 a month being spent on 85-year-old people who will meet the criteria for Alzheimer's, but whose experience of Alzheimer's will be extremely different than the experience of the younger person. Not that Alzheimer's in an older person isn't tragic, but I'm talking about the actual expression of the illness, the actual extent to which it progresses, the actual domains of the brain that are involved, the actual disease experience for them will be different than it is for the younger people, and it will be different as a consequence of the many of the things they have wrong with them. So again, there'll be some 85-year-olds in whom it's their only illness, and the illness of Alzheimer's will be the exact perfect metaphor for them. It will look like that with them like it did in the younger people, but that will not be the majority case. And in those people, I don't think we would have any desire we will get no benefit back from spending $2,000 a month on drugs. And we get a whole ton of benefit back from spending $2,000 a month on nursing salaries to care for them, because that's what disease expression is going to look like in them, is my bet. It will not be preventable in the way that it is in people with one thing wrong. So let me sum up by saying that what I've said to you today is that the fact that as people grow older, on average, they get more things wrong with them underlies the tendency for people to die as they get older. They die as a function of the many things they have wrong with them. Equally and surprisingly, as a function of the many things they have wrong with them, even when these things themselves, even when the individual things themselves don't look like they should cause dementia, as people get more things wrong with them, not only do the risk of death goes up, but the risk of having dementia goes up. I've said that when someone only has one thing wrong with them, that at any age, the metaphor of their illness, their Alzheimer's will look like everybody else's Alzheimer's if people have one thing wrong. But when they have many things wrong with them, their Alzheimer's will look different. And in general, it will be a more benign course on average than it is when they have only that thing wrong with them at any age. I've said that the challenge of people with multiple interacting medical and social problems, of which dementia is probably the toughest, is a challenge for healthcare. And because dementia is so strongly age-associated, it will increasingly become a problem for the way we provide acute healthcare now, and one that we must face up to in terms of the way we organize a service and the way we train care providers and so on. But the change which we must engage in right now is the attitudinal change, which sees these people not as troublesome, but as the very crucible, the challenge for us, the challenge that we must face, the way that we can shine. I said to you at the start, and I feel so now, I'm very optimistic about our ability to take on the challenge of Alzheimer's as a challenge that's worthy for us, as a challenge that we can meet, as a challenge that we can organize ourselves and organize our attitudes to make sure that we are able to address. We are very fortunate to live in a very great part of a very great country with a lot of culture that tells us to honor each other and to honor older people and to help out the person in need. It's all of those things which are going to be our great strength as we go forward to meet the needs of an aging population. Thank you very much for listening.